All right, let's dive into this explainer and completely demystify the complex pharmacokinetics of local anesthesia. We're going on a bit of a journey today, zooming way into the microscopic level, looking at how these drugs actually interact with our cells, and then zooming back out to the macroscopic, real-world clinical applications. Basically, we're looking at exactly how we manage to temporarily hit the mute button on the human body's alarm system.
To keep things moving, here's a quick look at our roadmap. We'll cover the nerve blockade, pharmacokinetics, esters versus amides, clinical techniques, systemic risks like LAST, and finish up with some key takeaways.
So, starting right off with Section 1, the nerve blockade, and its mechanism of action.
Okay, so every single local anesthetic is built on three crucial structural components. You've got the lipophilic aromatic ring, the intermediate linkage, which is going to be either an ester or an amide, but we'll get to that, and the tertiary amine. And this is absolutely crucial. Each one of these individual components specifically dictates how the drug is going to behave once it actually enters the human body.
I want you to think of the nerve cell membrane as this heavily guarded wall, right? And our anesthetic drug, it's basically an undercover agent trying to slip past security. Now, because these drugs are weak bases, they exist in two alternating forms, ionized and unionized. But here's the catch. To actually reach the inside of the cell, it can only cross that wall in one specific form.
So here's how that infiltration actually plays out. Step 1, the drug shifts into its unionized form so it can sneak right through that lipid membrane. Step 2, the second it gets inside, boom, it reionizes. And step 3, this newly reionized portion acts literally like a wedge, jamming the sodium channels closed from the inside. Without sodium flowing in, no action potential can fire. The nerve is completely blocked from sending a pain signal.
Moving right along to Section 2, pharmacokinetics focusing on onset and duration.
When we're talking about how these drugs perform, it really all comes down to speed versus longevity. Onset speed is driven by things like dose and nerve size, sure, but it critically relies on the drug's pKa. Drugs with a pKa closer to our body's natural pH have more of that sneaky unionized base available, so they hit much faster. Duration, on the flip side, is dictated by protein binding. Basically, the tighter the drug binds to the proteins inside that sodium channel, the longer your blockade's going to last.
Let's jump into Section 3, classifying these drugs into esters and amides. Remember that intermediate linkage we talked about earlier? Well, that's exactly what divides our tools here. Esters, like procaine and cocaine, have a really short half-life because they're broken down super rapidly in the blood by plasma esterases. Amides, on the other hand, think lidocaine or bupivacaine, rely on a much slower metabolic process over in the liver. It's this exact structural difference that tells a clinician which tool to grab for a specific procedure. If we look at two really common amides side by side, that trade-off becomes super obvious. Lidocaine acts incredibly fast. We're talking under a minute, but it's only going to last you about an hour. Bupivacaine, that one might take up to 10 minutes to really kick in, but you're getting sustained relief for 3 to 4 hours. It's all about picking the right tool for the job.
That brings us to Section 4, clinical techniques and applications.
So before you can inject anything, you obviously have to safely locate the target nerve. And practitioners generally do this in one of two ways. They might use ultrasound visualization, where they can literally watch the needle approach the nerve in real time. Or they might use a peripheral nerve stimulator, which actually induces tiny physical twitches in the patient's muscle to perfectly guide the needle's path. It's pretty fascinating stuff. And mastering these identification techniques unlocks a huge array of blocks across the whole body. We're talking everything from an upper limb brachial plexus block down to a simple digital block for a finger, all the way to major lower limb and regional procedures like spinals and epidurals. And the clinical advantages here are just massive. Highly localized pain relief means way less post-operative nausea, patients are up and walking way earlier, there's a decreased risk of post-op thromboembolic episodes, and honestly, even less overall theater pollution compared to pumping general anesthetics.
Now we have to talk about the risks. Section 5, managing complications and toxicity.
This right here is a critical safety warning. Local anesthetic systemic toxicity, which we call LAST, is no joke. It escalates incredibly fast. It hits the central nervous system first, presenting with early warning signs that might seem minor, like a metallic taste or numbness around the lips. But if blood levels keep rising, this spirals rapidly into visual disturbances and slurred speech, and could eventually lead to severe, life-threatening convulsions, a coma, or total cardiovascular collapse.
Because last is literally life or death. Prevention is absolutely paramount. To prevent an overdose or a disastrous direct intravascular injection, these 3 preventative steps are totally mandatory in practice. First, you meticulously calculate and stay completely within the maximum safe dose. Second, you always perform an aspiration test with your syringe to make sure you haven't punctured a blood vessel before you push the drug. And third, utilizing vasoconstrictors, like adrenaline, can really help keep the drug localized and slow down any systemic absorption.
All right, let's bring it all together and wrap this up with Section 6, Key Takeaways. I've laid out the most important information right here for you. Just remember these core pillars. 1. The unionized form sneaks in, but it's the reionized form that actually blocks the sodium channel. 2. Onset relies on pKa, while duration relies on protein binding. 3. Amides are metabolized slowly in the liver, whereas esters break down really rapidly in plasma. And 4, perhaps the most critical, always aspirate your needle to prevent systemic toxicity.
These localized drugs truly are modern medical marvels. But I want to leave you with a final thought today. We've clearly mastered temporarily blocking the body's alarm bells using these chemical undercover agents. But as medical science continues to rapidly evolve, how close are we to figuring out how to turn pain off entirely without facing any of these systemic risks at all? Something to think about. Thanks for joining me for this explainer, guys. Keep learning, keep questioning, and I'll catch you in the next one.